I'm Jessica, and I'm one of the secretaries for Club Med Virtual. First, I would just like to thank everyone who is attending today, and especially Goodcoff for taking time to be here with us and giving us this amazing opportunity. Before we start, I would just like to emphasize to keep proper etiquette, to not unless Dr. Goodcoff specifies to. Video should be turned off, and near the end of the sessions, one of our VPs should be posting a link for the summary of in order for you guys to obtain shadowing hours, you must complete the summary and it will close 30 minutes after the session ends. Once Dr. done, just please stick around for about 5 minutes to ensure that you all get the link. And then since this session is more of a Q&A type of session, just please ask your questions in the chat. Dr. Goodcoff and myself can monitor it. If everything's all set, then Dr. Goodcoff, you may start.
Excellent. Thanks, Jessica. So thank you very much for having me. Actually, I'll keep you unmuted for a second. I'm just curious, where are we talking to, or in the world, in the country?
We are all, most of us are all Wayne State students, which is located in Detroit, Michigan.
Okay, very cool. So not too far away from where I'm at right now. So a little bit about myself. I am an emergency medicine resident. I am a first year, an intern in emergency medicine here in Chicago. I did medical school in West Virginia, and I'm originally from New York. So I've kind of covered the East Coast and now come out west a little bit. My goal today, if any of you have seen any of my social media stuff, I do a lot of education. I actually did an extra year at the end of medical school for a teaching fellowship. So I'm very big into teaching, medical education, and obviously social media. And yeah, I'd like to just kind of answer your guys' questions. I think it's funny hearing you talk about the board and stuff. I was the pre-med club e-board president when I was in college. So I know what it's like. I know what it's like sitting through the talks, and I never really liked when people gave these like boring long talks about things that really didn't apply to me at that point. What I kind of wanted were my questions answered, or at least a direction, specifically an experience that I wanted to hear about or something. So I figured I would open up this, 30, 40 minutes, whatever we have, to kind of answering your guys' questions or sharing different experiences that might help all of you kind of figure out where you're at. So feel free to drop in the comments as we go, questions that you have, things you want to know more about. I would like, just out of curiosity, to get a feel for where everyone's at. If you can drop in the comment what year, whether you're a freshman, a junior, a sophomore, senior, whatever it might be. Some seniors here. All right, cool. Oh, a lot of seniors. All right, nice. I got the chat open now. Some sophomore. Okay, so good mix. Cool. All right, so that's popping in. So it's a pretty good mix. Looks like a lot of upperclassmen though. I guess kind of starting this off, we'll use the chat for this. Who is applying this year? Just comment yes if you're applying this year, no if you're not. Okay, so a little bit of, just a few students this year, not a ton this year. So that's good. We don't have to spend a ton of time on that. I'll just start by kind of clearing the air about applications this year. Applications this year are going to be difficult. They're difficult for everyone. I do a lot more at the residency level now, to be honest, than I do at the medical school admissions level. But I have been there. It's going to be tough with COVID and not having in-person interviews, and trying to find out who you are as a person is hard to do virtually. So if you are applying this year, don't sweat it. Everyone's in the same boat. If you're not, count your lucky stars. Maybe this is the way it'll be forever. Maybe it won't, but I think in-person interviews are very helpful. But as you've seen, scores are less important this year because it's difficult for certain people to get to testing centers and actually get to take tests. So I think we'll kind of clear the air on that one. I think it'd be kind of helpful, because this, in my mind, this session is really for you guys. So what would you like to hear about? I mean, do you want to hear what it's like to be a resident? Do you want to hear what medical school is like? Do you want specific advice? What's going to help you guys the most? And just use the chat for that. I'll give you some time to kind of drop some stuff in there, and that way we kind of have a clear direction to go to make sure I'm providing the most value for you guys. Yeah. So what's med school like? That's an easy one. So I'll just kind of start at the top of the list and work down. So my time in med school was fantastic. I actually really enjoyed medical school. It's not a popular opinion. Not a lot of people will share that opinion. I think if you go into it with the mindset that this is your job and you're working full time at this job, it's not too bad. If you have any friends that go into the workforce at the same time, they're going to have kind of these boring 9 to 5 lives. Their job doesn't really have a whole lot, generally, doesn't have a whole lot of satisfaction. They're kind of just working for a paycheck. And you're going to be learning things that potentially will save someone's life someday. And if not even save someone's life, it's going to give you a sense of fulfillment for just expanding your knowledge and understanding the human body and understanding medicine. So my time in med school was great. I worked out a lot. I got to travel a ton. If you want to see specifics on this kind of stuff, not only do we obviously have the blog, the Instagram, but I have a couple of YouTube videos that gave like day in the life type stuff and experiences. But yeah, I did more travel in med school than I had ever before in my life. So I got to do a lot of that. And then again, just, working out and eating clean and then spending the rest of the time studying and taking it like a job. So a little more here kind of looks like what is medical school like? I think it's hard to pin it down. I always tell people college, depending on what you did, for a major, college can be harder in terms of the actual subject matter, but in terms of volume, it's not even close. The flow rate in medical school is just so much faster. So the material is easier, but it's 4 or 5 times the rate that you would see in college. So you're spending kind of less time sitting there confused and more time just confused about how you're going to get all that information in your head. What else is it like? The first 2 years are very didactic heavy. Depending on your program, you may get to do a little more clinical, a little more with like simulations or standardized patients, but for the most part, it's pretty limited. And then third year, you're kind of out on your own a little more. And fourth year is really about applying. I have a whole other theory where I really think med school should be like 3.5 years with one of the summers missing, but I won't get into that for today. So yeah, fourth year, you're more on your own. It's almost kind of like you're an intern. And actually the transition from being a fourth year to an intern is kind of an interesting one that we could always touch on later. So let's see. We'll kind of move on to the next question. If you guys feel like there's anything I'm saying you want more clarification on or more detail, just drop it in the comments. Yeah, so my experience in emergency medicine. So obviously I've been doing this for 4 months, but it's kind of not really just 4 months. I was in EMS for 5 years, all through college, through the end of high school, through college, right up until the day I started med school. And I worked, 70 plus hours a week doing that. Towards the end of college, it wasn't always that high on the hour rate, but the point is I've been in this game a while. I know what it's like, I knew what I was getting into. So I think the people that run into a lot of burnout are the physicians who do this because of the lifestyle or the money. And, they're not ready they think they're going to be doing a lot of, let's say, codes and, like crash section, comorbid section type, I can't think of the fancy word, but postmortem section, thoracotomy, like those type of crazy procedures. And it's really not, even intubations and central lines, like, do we do them? Absolutely. Do I do them every single shift? Absolutely not. There are shifts where I do 7 belly pains and 2 runny noses, and that's the whole shift. There are other shifts where I intubate 2 people and I get to put in a chest tube. So it just depends. But yeah, part of the burnout rate is the patient population you work with. They can be very difficult. We'll kind of leave that at that. And then a lot of it is the pace. It's very, very fast paced and very stressful. And yeah, a lot of it is kind of that always on. You're always worried about what you're going to miss. And that's something that I think actually I'll touch on. A lot of people miss with emergency medicine is that it's not about making the diagnosis. And this is where a lot of patient satisfaction issues come. They come to the ER, they have belly pain, they want to know why their belly hurts. And that's not our job. Our job is to evaluate them, make sure there's nothing life-threatening that's going to kill them in the next 24 hours. And if they're safe, send them home. And if they're not safe, admit them or have the appropriate specialist to come see them. So we are a specialist just like everyone else, but our specialty is making sure that you don't die in 24 hours. And it's kind of silly to think of it that way, but it's a totally different approach. You know, in medical school, you learn I need to diagnose and treat this disease. And for us, we're really more I need to evaluate for these conditions. And if it's none of these conditions, I don't care what the diagnosis is right now because I know you're not going to die in the next 24 hours. So that's kind of a change of thought in emergency medicine. Let's see. What's med school like and advice for pre-meds? I think we kind of touched on that pretty well with like what is medical school like. Advice for pre-meds is just make sure you really want to do this. I know shadowing is tough. Going to events like this is great, and being able to ask your questions and kind of get your specific things answered. Social media has become a great tool. TikTok, Instagram, YouTube, especially. You know, and if you don't already, check out our YouTube. Please subscribe. We have some exciting kind of shadowing stuff coming up where we're trying to get the camera more behind the scenes, which is very, very difficult, I can tell you, just legally, but certain places it can be done. And so we're trying to do more of that to give students a chance to kind of like virtually shadow and see what it's like. But yeah, make sure you have a real solid reason why you want to do this, because it's not an easy road. There are going to be times where you doubt that you can do this, just like there are in college. You know, there are still days where I come home and I'm like, what am I even doing? So you need to find a reason for why you enjoy doing this. Applying for med school, that one's kind of real broad. See if we can kind of reel that in a little bit. Let's see. My daily routine during residency, I wish it was the same. So right now I'm on obstetrics. So I get up, I'm in Chicago, so I get up Central Times. I guess it's an hour behind you guys, but I get up at 5 a.m. on the nose. I try to shower the night before, but sometimes I don't. So whatever I need to do, get showered, make breakfast at light speed, and try and eat it before I'm late. I live about just under like 15 minutes from the hospital. So run downstairs, get in the car, get to the hospital, sprint up to the floor, just make it in time, change into scrubs, and then I round on all of the postpartum patients. So those that have delivered, I write notes on them. And once I have written my notes, I go say hello to any of the women that are on the labor floor that day that are going to be delivering. I introduce myself, write notes on all of them, write notes on anyone that has MAG. You'll notice in all of medicine, there's a ton of documentation. So you got to get all your documentation. And then I actually hang out. I do a lot of studying on this rotation because if there's no one delivering and I carry you have like a floor pager. So if something happens on the floor, they can page me and get a hold of me. And there are other actual OB residents. This is considered an off service. So if you ever hear that term off service, that's when someone from a different specialty, emergency medicine, rotates through another area. So just like a medical student rotates, we rotate. The difference is now you're a doctor and you're actually responsible. So it's not quite as fun. Like as a med student, you can rotate through surgery and just watch and observe and nothing happens. There's not really many notes to write. Now it's different. And you have to remember that making decisions is not really your scope of practice. And if you make a mistake that hurts someone, it's kind of on you. So you need to be careful. I run things by the seniors a lot because I'm just where I'm confident in emergency medicine and doing my own thing in the ER, not as confident on the floor. And I certainly don't want to make a mistake with like a mom or a baby or something like that. So I hang out all day in a call room studying. Every 2 hours, I check on the laboring women. I go downstairs, check in with them, do a quick exam. And then, of course, I deliver the babies as they come. So I get out around 5 p.m. my time. I try and get out on time. You know, it takes a little bit of time to get home because of traffic. And then I usually hustle to get over to the gym. Unfortunately, it didn't happen today. I actually went down to the ER to help out with a very interesting case there. So I stayed a little bit later. I stayed like an hour and a half late. But yeah, I'll usually get home, I'll go to the gym, then I'll come back, make some dinner. And honestly, I was actually talking to my dad about this the other day. I don't know where the remaining hour goes because I get back from the gym and shower and it's about 8 o'clock and I try to go to bed by like 9:30 so that I can get up at 5 the next day and be pretty functional. And I don't know, I'm not sure. Sometimes I watch Netflix, sometimes I read like on cases and things. A lot of times I'm catching up on email or social media stuff. It is a lot of work behind the scenes for all the stuff that I do. So sometimes it's that, but yeah, that's kind of the full day. The nice thing is this schedule is pretty packed on ED blocks where I'm working in the ER. it's not quite as bad. I don't work every day of the week like I do here. I work in like sets. So the trade-off of that is some of them are nights, some of them are days, some of them are swing, which would be like, 3 p.m. to 11 or something like that. So it just varies. And I saw, to piggyback off that, what are my hours like? It just depends. Some weeks when I was on trauma, I'd be working over 80 hours a week. When I'm on EM, I generally work about 55 to 60 hours a week. It's a lot better. So, on OB, I don't know. I need to enter my hours. Whatever, 11 times 4, and then there's like a 13-hour day in there. So it's not that many hours. It's probably like in the high 40s, low 50s. So it's not too bad here. But like I said, on trauma, I was working, 80 hours a week consistently. Let's see what else we can do. Yeah, what do my extracurriculars look like? Research, all that stuff. Yeah, so I'll do my best. Like kind of thinking about this talk, and that's why I want to make a question and answer. It's been a long time since I applied to med school. I was thinking about that, especially because I did the extra year. So it's 5 years of med school, and now I'm in first year of residency. So it's been like, plus you apply really a year early. So it's been like 7+ years, 8 years since I applied. My extracurriculars had a lot of EMS stuff on them. I was an AHA instructor for both BLS CPR, but then I also learned how to teach ACLS and PALS, so the 2 advanced certifications. And I taught for the ambulance company, and I also worked for a private company, so that was kind of nice. And then I had a lot of research. I actually, when nanobioscience was new, I was involved with nanobioscience research with like wafer-based stuff, those 460 nanometer wafers or whatever. So I got lucky and got plugged in with that. I did some actual like battlefield research that came back from Iraq, and we were testing in a hospital for this like a tissue perfusion sensor. It's kind of interesting now. Knowing what I know looking back is kind of cooler. I didn't really know what I was doing then, but so I had that, and I was a big swimmer in high school. Didn't want to swim in college, but still had obviously a lot to bring to the table. So I coached our college's club team. So that was kind of another unique thing that I had on there. Pre-med club president, obviously did a lot of work with that. So I had a bunch of stuff. I had a pretty deep resume. To be honest, my med school application is probably not like a great one to compare off of, because I had multiple admissions counselors that kind of reviewed it and were shocked. When I first applied, the thing that held me back was my MCAT, and I refused to retake it. And I did get in the first year, obviously, and I am a DO, and I applied to a ton of DO schools after I got my score back, and I'm very open about that. It's not like a secret. I applied to like almost exclusively MD programs with like 5 DO programs, and then I saw my MCAT score, and I was like, that's not going to happen. So I applied to a ton of DO schools, and everything happens for a reason. I honestly think it's one of the best things that happened to me. I'm very happy with how things worked out, but it presents its own unique set of challenges. And so anyway, going back to my application in particular, it was very stacked compared to the traditional DO applicant. And so it was nice because it gave me a wide choosing. I could pretty much pick where I wanted to go in the DO world. But it also put me in a bit of a weird position where they were like, why do you have so much research, and why do you have, such high academics? Basically the only thing that doesn't make sense is your MCAT. And so there were some schools that weren't really interested because they thought I was just applying as a backup or a safety. So presented some weird challenges, but I'm not the best to ask about that. Let's see. What advice do I have for a first year student, like a first year med student? So for a first year med student, and I'm actually mentoring a first year med student right now, I tell her the same thing that I would tell you, is to just keep your head down, work hard. When you think you're working hard enough, work harder. It's about learning knowledge. This is actually, you take one thing, everybody listen up, put your phone down, whatever it is. I don't like that I don't have videos on. See, when we have our residency didactic, we make everyone keep the videos on so we know people are paying attention, but whatever, that's fine. What's that?
We can try. We're welcome to put the videos on.
If people want to, they can. I feel like otherwise I'm just staring into my own face.
Yeah, I'll keep.
Let's give some personality to you guys. Yeah, it's nice. Very cool. Yeah, so I'm glad you're all paying attention. I totally doze off on my phone, so I get it. Zoom, death by Zoom, as we call it. What I would say is take one thing away from this entire presentation, and that is um, learn to learn, which is like the stupidest quote on planet Earth, but like learn things to actually physically increase your knowledge, not to get a score or a grade or an acceptance. Um, it takes a lot of students a long time to figure that out, probably like their whole life as a student, and they still don't figure it out. And it's unfortunate because they'll never be the student that they could be. You want to know, everyone's like, what's the secret to a good board score as a DO? I'm like, there is no secret. Learn the material like you actually care about it, and I promise you're going to crush the test because it's not hard. None of these tests, and the same, I can't speak to the MCAT because I never took it again and I was young and I didn't know these things when I took it. But I can tell you, like, step one and step two, these tests that people will say like, oh, they're bullshit, they're not real, like this isn't real knowledge. Like, it is real knowledge, and it's stuff that applies every single day, and it's stuff that I sadly don't remember because it's hard to remember all that information. But if I knew all of the random factoids that I knew when I took step one and then again for step two, I would know a lot more, or I'd at least have like a good explanation for a lot of the stuff that I see. And it's normal that you lose some of that knowledge and you build more clinical knowledge, and it's just part of the process. But the point is, I put that in for a foundation, and a lot of students don't, or along the way, they just memorize things because that gets them the score. And it will. Med school, like I said, the volume is very, very high and the pace is very fast, but you can memorize it. And some people will memorize or do whatever it is they can to memorize it, but they'll forget it and then they don't do well on boards. And so the difference is, you might have someone, and this happened actually, both my roommate and I had very similar scores, and we both kind of hovered in the high 80s, low 90s. We were never like the top scorer on the test, and no one really thought much about us. And then when board scores came around, we're in the top 20 scorers in the class, and people are like, whoa, where did they come from? And it's like, you get these people who are all along the way actually studying, actually learning the material to build this deep knowledge base. And then when it comes to applying it to new concepts, you can actually do that rather than just having memorized facts for a score. So definitely take that away. But let me try and go back to whatever question I was on here. So that would be my advice to a first year. How has COVID changed views about my job? I don't really have a good one for this. So you ever, I don't know what it's like in Detroit, but if you've ever met someone that comes back from war, and mind you, this is not war, like that's a far scarier proposition, but someone that comes back from war, they like do more reckless activities. They like look at life a different way. They just kind of like live it to the fullest. I don't go to war every day. I don't fear like going to work, but it's noticeably different. And the feeling that I had when I came to residency and came to a big city that has a lot of COVID, and having never seen, I mean, I never saw a COVID patient as a med student because we were pulled off rotations and I was living at home. I was quarantining. My dad has a kidney transplant, so it was especially important for me to quarantine. I wasn't seeing my friends. I mean, fourth year was like ruined, which is silly to say in the grand scheme because there are people that lost their lives. A lot of people, 200 something thousand to clarify against the president's comments. But a lot of people died and it ruined a lot of people's years. Everyone, 2020 is a joke of everything. And so coming into a big city, coming into a residency program, being a doctor, starting in all of this was like, whoa. So you either take the road of being afraid of everything, which some people I know did, or you just look at it like, I don't really have a say in the matter. I have a job to do. I need to go to work. I need to do my job, do it as best as I can, try and stay as safe as I can, and hope that I don't die doing it. And as we've done this more, we've found that you're not necessarily going to be like walking around dying. And you can usually get COVID as a young, healthy person and be okay. But that said, I do have friends who got COVID and have heart failure and are on medications now. So I know of physicians who died during the pandemic. It's still happening for those who don't believe that. We still see COVID cases. So I don't know that it's changed my view about my job, but it's kind of changed my outlook on what I do. It's shown how much we take for granted, and how important it is to be careful for yourself and for your patients. And I think one thing that is done positive is normalized protective equipment for yourself, wearing a mask, wearing gloves, washing your hands all the time. So if there's anything positive, a silver lining, it would be that. But yeah, it was a little bit nerve wracking at first, but kind of like I said, like someone who kind of goes to war and they see like the bad side of it, and you either come to that moment where you're either going to live in fear or you're going to say, this is my job and I'm just going to do it the best I can and hope that it doesn't get me. And I could be giving this talk right now, having seen someone with COVID today and, you know, have respiratory issues in 3 days from now. Who knows? I doubt it, but it's possible. So it's kind of like, you never know, and you can't let it stress you out. What did I struggle with most? Yeah. What did I struggle most with when I was a pre-med student? Organic chemistry, probably. No. It's a tough question. And I think what was hard for me isn't what's hard for you, isn't what's hard for the next person. So me telling you like a woe was me story about something that I particularly had a problem with in college, I don't think is going to necessarily help. I think the important thing to remember is that everybody has their struggles, everybody has their issues that they run into, and it's not about the number of those or how serious they are, but how you overcome them. At some point in your life, somebody is going to die in your family. It is not going to be fun. It's going to derail your mental progress and your, you know, emotional progress and all that stuff. That's a given. So that's something to prepare for, whether that happens in college or medical school or residency. Life happens, just like we see in the ER every single day. People are born and people die. So it's one of those things that's inevitable, but doesn't make it easier. That could be a struggle. You could have an emotional, you know, struggle with depression, anxiety, something like that. There's more openness now than ever about mental health. And, you know, there's no shame in getting help if that's something that you need. You can have an academic struggle, you know, a physical struggle with, you know, weight or body image or whatever it is. So there's, you know, there's a million things, and everyone's going to have their unique challenges. So I would say own it and deal with it head on, and don't be afraid to kind of sort out your issues. Don't just push through, because I call it like kicking the can. Like if you try and kick the can, you can kick the can for a while, but then at the end of the day, you have this mountain of a problem that you've been dragging along, and you know, you're gonna have to deal with it at some point. So do it sooner than later. So, all right. Explain. I'll do trauma after this. This one will be just quicker. My extra year in med school. This is a teaching fellowship, so I taught the anatomy course to the first year medical students. It's kind of complicated. The year was split into like 32 weeks, 36 weeks, however it divides out. 26 weeks as a clinical medical student, and then 26 weeks as an actual faculty member. So I had an office on campus, and I was not a true professor, but like a faculty member for the anatomy lab. I was, you know, designed their tests and sat on the board meetings with the dean and all of that jazz. So I got to experience what academics was like, and obviously the responsibilities associated with it. And I got a stipend, and they also paid for my tuition. So I've only paid for 2 years of medical school. What they didn't pay for was cost of living, so I still had to take money out. So I still have plenty of student debt. Yeah, and then I also did some ultrasound. During that, I'm not sure how, but we came upon 2 handheld ultrasounds, and so I taught myself ultrasound with books and videos, and then ended up doing research on ultrasound and medical student ultrasound and stuff like that. So it's been, it was kind of like a sentinel paper to get DO students to start doing ultrasound earlier. So that was pretty cool. Let's see. What was my experience while on trauma rotations? So trauma is not as sexy as it is on TV. On TV, everybody is shot and bleeding out and goes to the OR, and then they're better. And in reality, people are shot and they come in and they die. Or they're shot and they come in and they're totally fine. It's one or the other. I would say very, very rarely does somebody get shot, go to the OR, and come out fine. It's kind of one of two things. Bullets are pretty unforgiving. And so it's either lodged through and through or lodged in soft tissue or something unimportant, or it's gone through your chest, taken out a lung, taken out a massive artery, and there's probably not going to be anything that we can do to save it at that point, given the time and stability of the patient. So the other thing to remember is that as an emergency medicine physician, that is an off-service rotation doing a trauma, because trauma is run by surgery. So you're with trauma surgeons, and I'm not a surgeon and I don't like surgery. So I generally, one time I had to, but generally don't have to go to the OR. So it's about stabilizing the patient. So you're on call for 28 hours at a time. You are awake for 28 hours. So process that number. That would be like us talking right now, and then us talking again tomorrow at 7 p.m. And then 4 hours later, me saying, okay, I'm going to leave now and go home and go to bed. So it's a ridiculously long shift. You do that every third day. And you cover the floors in the hospital, which is it's another thing that is not one of my favorites. All of the trauma patients that are admitted to the floor are your responsibility. All the patients that get stepped down from the ICU to the floor are your responsibility. So you're taking care of all of them, writing notes on all of them, answering tons of phone calls on all of them all the time. And then in between, you're getting activated for traumas, going down to the ER, doing a full trauma assessment. And it's a very algorithmic assessment. So you go through all of that, and then CAT scan the patients, do any other imaging you need, and admit them to the appropriate place or the OR if they need to. So I got to do a chest tube, which is cool as an intern. I didn't do much else. I do a lot of ultrasound, did a lot of fast exams, which is scanning in a trauma assessment. But yeah, it's not awesome as an intern. It just kind of is something you have to do. So, but yeah, what do you see? What do you deal with? A lot of trauma. I'm in Chicago. You guys are in Detroit. You know how those cities work. A lot of gunshots, a lot of stabbings, a lot of motor vehicles versus bicycles and people. Probably more of that actually than gunshots. But we did see a lot of gunshot wounds as well. At some point, the awe of seeing it just kind of wears off, and you just are treating the problem and going on to the next one. I think if you don't look at it that way, it probably would get to you over time. Let's see. DO med school. Yeah, so my experience in DO med school, especially with some of the slander that's going on in the media right now towards DOs, which is borderline comical at best. I'll clear it right now because I don't think I really even knew. Like I said, I wasn't planning on applying DO. I didn't really know anything about it. There is no clinical difference between a DO and an MD in the US, period. There is no qualifying statement, no question, nothing. Nobody should ever ask you anything else. Can you write prescriptions? Can you do surgery? They're all stupid questions, and you should tell them that is a stupid question. Because at this point, we are so widespread and so mainstream that it's actually a stupid question to ask that. Our hospital right now is one of the few level 1 trauma centers in Chicago, and I would say I see a 50-50 split of DOs and MDs on the floor, so, and in the department. So I think it is definitely getting more and more common. There are pluses and minuses to both. I think if you want to go do cardiothoracic surgery or neurosurgery, you should be an MD. And I don't think that's because you're going to get better training. I think it's because those people in those programs are old. They have old mindsets. They're unwilling to open their eyes and have an unbiased evaluation of someone. Sadly, that still exists. It exists when I applied for residency. There was one program which will remain unnamed that I interviewed at that told me that they wanted to have some diversity. And I don't know if you can tell from this glaring white light, but I'm pretty white. So I'm not really a diverse person. I'm a nice person, but if you're looking to make your diversity numbers go up, I'm probably not the guy. So I'm sitting there in the chair thinking, what would they possibly want with me? And this program director looked at me and said, we're ready to take a DO now. And I almost fell off my chair. I rotated with them for a month. I had the clerkship directors were saying I was one of the best students that they had worked with that year. And the reason that they wanted me was not because of my skills in the department or my ability to perform procedures, was because I would be diverse and I could be the first DO that they would accept. So I politely declined that. And I think in some ways being a DO puts that extra pep in your step to prove to people that they're wrong about whatever their preconceived notion is. And I would actually confidently say that most places you go, preceptors that have been doing this for more than a year will say, yeah, we actually prefer working with the DO students. I've heard it time and time again. It's not been directed towards me. It's just things that clerkship directors will say. DO students are better clinically. I'll say that for a long time. There are great MD students that are great clinically, and I'm not saying they don't exist, but I'm saying if you took a sample of 100 DO students and 100 MD students, I think generally you're going to get more clinically competent medical students out of the DOs. And maybe it's because we spend more time doing clinical stuff earlier on. I'm not sure what it is, but I've always had good experiences. Obviously, I'm biased, but that's what I've been told from other professor type people that work with medical students. That said, like I said, if you want to do something very competitive, don't fight the system. It's not worth it. If you can get into an MD school and you want to do neurosurgery, just do it. Make your life easier. For reference, another story to make you realize how ridiculous some of this is. I had a friend that was applying emergency medicine the same time as me. She shared her STEP score with me. Now, STEP is out of, and my STEP 1 score is not a secret, so I'm happy to share it for reference here. It's in one of my YouTube videos. Her STEP score, I want to say, was a 215 or a 216. Passing is like a 195. A good score would be a 225 or higher. A competitive score is above 230, and a really like excellent, like you can go do ENT type score almost, is usually like a 245, to give you reference, because I know these numbers mean nothing. So she had a 216 or something, which as a DO would pretty much disqualify you from matching anywhere, or anywhere competitive, at least for emergency medicine. You pretty much as a DO need a 230. And I keep saying as a DO. So I applied to tons of programs. I got tons of interviews, but there are still places that hold their views. She was worried she wouldn't even match emergency medicine at one. She wouldn't even get one interview offer. So she applied for pediatrics also at the same time. And not only did she get interview offers, but she got interview offers at Hopkins, at Yale, at Brown, at Penn. I didn't hear from any of those programs. So I had a 236 and she had a 216. I had like 7 articles of research and 2 published papers, one of which I was a first author. She had 0. She was an MD. So it still exists. And it's going to just be up to you as an individual to continue to break that stereotype down. If you go to DO school, don't let that shake you up. The one thing I will say, and this is still different, is just be careful if you choose to go to a Caribbean school. Yes, you will be an MD, but your life will be much harder trying to get a residency. I would say at the programs that are still picky, it is USMD, USDO, Caribbean. Doesn't mean they're worse doctors. Again, I've met some incredible doctors out of the Caribbean. They're usually the ones that work really, really, really hard, but the Caribbean medical schools are also all about making money. And it's a whole nother discussion that we can get into at another time, but nothing wrong with it. Just keep that in mind. You're going to have to work very, very hard to make sure that you can get a spot. Does that kind of answer? Is it Shahani's question? Yes. Okay, cool. Whoa, it's moving. Did the curriculum include psych? Yeah, absolutely. We cover psych. Psych is on boards. I'm not sure who RQ is. I can guess, but yeah, we do cover psych, and it's just like anything else. If you're passionate about psych, you can learn more about it. If you're not that passionate about psych, you just do what you got to do, and you learn it again for that knowledge base, and you kind of move on. We have a huge psych problem in this country, and I'm very thankful for the great psychiatrists and psychologists that we have, but it takes a special person, and it is not my favorite area to work in. So let's see. How to meet DOs willing to write you letters for your application during COVID. I will probably regret saying this, but I will consider writing you a letter if you send me your resume and a nice email about yourself slash potentially do like a 10-minute Zoom call so I can at least say that I know you. Is this Lindsay? So wherever Lindsay is, if that's something that you're interested in, you can email me. Hi, I see you there. Yeah, shoot me an email and we can try and get that done. I was really lucky. I knew a DO from the ambulance that I worked at. He was like the medical director and wrote me a letter. Those letters are also antiquated and stupid because as much stupid stuff as those old MD programs do, the DOs do a lot of really stupid stuff that drives me up a wall. One of which is trying to act really entitled that they have like this little secret club of DOs, and it's a terrible look, and making you get a letter and prove why you want to do DO makes no sense. They should be embracing intelligent students that want to come to DO school. So um, yeah, reach out to me if that's something that you need. That's not, if this goes up on social media and is being recorded, that is not an offer for everyone. That is only for those in attendance today. Yeah.
Thank you. I really appreciate that a lot.
Yeah, you're very welcome. I like I said, I appreciate how difficult it is, and I'm happy to help, but just not hundreds of thousands of people. Let's see. Okay. What made me choose EM? It's a good question. I always get this question in DMs. I'm always like, check out my posts, because it's true. It's hard to like summarize this in one word. There's a million reasons why I enjoy what I do. I think one of the biggest things for me is I like the emergent patient, the critically ill patient. And the only two ways to really get critically ill patients are to be a critical care physician or an emergency medicine physician. Those are the people in the hospital that get the critically sick people. And get to do the procedures as well. That's another big thing. So I think for me, I love doing procedures. Procedures is not surgery, and you'll find that out early. One thing for anyone that thinks they want to be a surgeon, find out early on in med school, can I live without surgery? Can I live without ever cutting on a person again? And if that answer is yes, don't do surgery, because your life will suck. Your outside life will suck. Pretty much everything will suck except for the fact that you get to do surgery. And there are people that are so hype on that excuse me, it makes sense for them to do that. They're that passionate, and that's awesome, and they make great surgeons. But if you're not, if you're just like, damn, I'm really good with my hands, that's the most toxic thing people say to med students. Like, you're really good with your hands, and they're like, oh my god, this attending said I'm good with my hands. Would you believe it? Like, yeah, okay, just don't do it for that reason, because just because you are good, and you may really be, you may have multiple surgeons say, wow, I've never seen hands like that. So what? If you're not obsessed, please do not do it, because the life of a surgery resident is very, very difficult. It's a 5-year residency. When they get out, they still usually have to do a fellowship, another 1-2 years. So you're talking 7 years of your life. And if you're doing this for money, again, you're going to do 7 years of your life and make probably less than I'll make after 3 years. So if it's about money, it's the wrong choice. If it's about prestige, nobody cares. So only do it for you. And trust me, the surgeons are plenty happy with themselves, so they may do it for themselves. I don't know, but yeah. So for me, emergency medicine was procedures. I knew I didn't want to do surgery. I liked procedures. I don't personally like long-term care. It's just not my personality style. I like to do things and move on. And I remember on family medicine sitting and having a well visit. I'm like, what's a well visit? And they're like, well, just go in and see how they're doing. I'm like, if they're doing fine, why would they come to the doctor? You know, like, which is, it's not how primary care should work, but it's just not my personality. I'm not the guy to sit down and be like, how are the kids? Yeah, they're doing good. Good. Okay. Great to see. How's the diet? You know, like, just not my scene. And if it is your scene, that's awesome. And you should own it and do it. And that's the same for everything. There's people, I don't love delivering babies that much. I think the process is not that fun to be a part of, and it's magical and it's emotional and not something that I want to do every day. And so, you know, OB was out for me, and you kind of like go through and figure that's not for me, that's not for me. And I always liked EMS, and so I'm like, I love procedures, I liked EMS, I like that it's quick. You see a lot of people, you feel good about what you're doing. I do, at least. You get to help a very vulnerable population, people that oftentimes don't have health care. They're very scared. True emergencies, which is like a freaking rarity, but I love, those people are scared, and you have a real chance to like make a difference in someone's life, being there for them when they're having a really bad day. So I like that. And it's only 3 years for residency. There are some 4-year programs, but it's another thing too. My roommate has a theory about a tank. Everyone has a gas tank, and it only goes so far. Some people it runs out after college. Some people it runs out after a graduate degree, so on and so forth. Like he's dead set. His tank is out after residency. Not everyone can do a fellowship. There are other people that finish a residency and do another residency. So you got to know your tank and know yourself, and it's okay. Like I said earlier, sort out your whatever problems and things in your head, and come to know yourself and make decisions for you, not anyone else. How is trauma versus EM? I think I pretty much just beat surgeons up pretty hard for that one there on the last answer too. So if you like surgery, do trauma. The thing I'll tell you, and I learned this as a pre-med, I shadowed a trauma surgeon, and he was like, well, I'm also a critical care doctor. And I was like, why would you do both? And he's like, well, we don't really operate very much as a trauma surgeon. And I was like, that's so bizarre. But that's what I pretty much told you guys in the beginning is they either come in and they're pretty much fine, don't really need surgery, they're really messed up and they're going to die before they get to the OR, or rarely they go to the OR for some kind of a repair. But in that rarely category, it's usually not even trauma that gets to do it, because if they have a nasty fracture, that's going to be ortho. If they have a vascular injury, it's going to be cardiovascular surgery. Only if it's a surgery in the belly, like a ruptured organ or a small bleeder or something, then trauma surgery will take them. So it's very limited. You don't get to operate much. So you go through all of that schooling, don't get to do much surgery. And it's just a lot of like management and sitting around. So it's not for me. EM, we see a lot of, I'll have, 6, 7 active patients at once. So I'll have someone who's having vaginal bleeding in one room. I'll see a trauma. I'll have another patient who has abdominal pain, another patient who's vomiting, and then another patient with chest pain who might be having a heart attack. And then an ambulance is going to come in with someone who's having respiratory distress. So you're seeing a lot of different stuff. And that would be like a very exciting 7 patients. Usually it's a little more chill than that, but so you're kind of working stuff up and cycling. It's just a very different workflow. How many schools did I apply to? Oh my God. I think I applied to like 40 or 50 MD schools. And then I ended up applying like 20 DO schools. Trauma surgery, I actually don't think it matters. Trauma surgery, surgery is not super competitive to get into. There are competitive programs, so people love to twist words, and especially if it's posted online. I can't wait for the messages, but like, whatever. I'm trying to give you guys the most real information. I personally think, and if you look at the application data, it is getting more competitive to do something like emergency medicine and less competitive to do something like surgery, which 10 years ago would have been the polar opposite. And it's because more people, I think, are looking at lifestyle over more smart people too, with higher scores, are saying, I like surgery, but I don't like it that much. So it is not super competitive to get into surgery, but I would say, like, if you have aspirations of going to like Harvard or Yale or something like that for surgery, if you can get into MD school, that'd be better. But yeah, let's see. Does med school attend? Yeah, it does, sadly. Yeah, always, reach as high as you can and make sure you're happy. That's the other thing too. I think one of the things I realized applying to residency is that the name doesn't really matter. I am at a very good program here in Chicago. I'm very proud of my program. And I really am happy where I am, but there were more prestigious names on the list that I had to rank. Ranking is how you decide in residency. So it's complicated. We won't get into it too much, but it's not like a job interview where you just say, thank you, yes, I'll take the job. Like, you list out all the programs in an order that you would like to go, and they list you, and a computer sorts it out and you match up. So you try to match your number 1, if not, your number 2, your number 3, so on. So there were names on there that were much, much, much bigger names, but I promised myself in the start of the process that I wouldn't get wowed by a name or trying to like make an impression or show people what a DO can do. And I was just going to do what made me happiest and find a program that would help me reach all my goals and keep me happy. And I think that was a big move for me to be able to do that. And I suggest you do the same. And so if you find 2 medical schools and one has a really big name and one is all right, but you love it there, the students are really happy, the faculty is very happy to teach, that's the school you should go to, in my opinion. Don't go somewhere that's malignant. Let's see. How do I go about patients that don't have healthcare? Do they still get charged? Yeah, so we treat people without healthcare or insurance, I think you mean, all the time. And they get the same care that everyone else gets, at least from us in the emergency department. The only difference is probably in the elective procedures. So let's say somebody has gallstones and it's not emergent. The surgeon's probably not going to admit them and do that procedure when they're not going to get reimbursed for it, which is unfortunate, but it's the way our healthcare system works. There maybe are some surgeons that do that. I don't know the specifics, and I'm truly not trying to throw surgeons under the bus here. I'm just thinking of like an elective procedure, because it truly is like someone who has asymptomatic gallstones. It's a finding that can be taken out, doesn't need to come out. Would they do that without insurance? Probably not. But if their gallbladder was ruptured, absolutely, they'd go right to surgery. And it's the same with with what we do in the ER. If somebody needs to be intubated or have a central line put in or any, expensive procedure, they're going to get that. I don't even know what patient's insurance status is, to be honest. I don't see it on the chart. I think it's probably in there somewhere, but it doesn't affect my care. So everybody gets the same care from me. And I think it's the same with all my colleagues. Awesome. Anything else? And feel free to unmute. I should have said that earlier. Is there anything you guys want to ask or add or, anything? Are you guys all on social media? Yes, no, maybe.
Yeah.
So.
Our club has its own. I'm pretty sure every student has its own.
Cool. Yeah, so I think social media is really important. It's becoming more and more important, especially in the digital application year. I hated social media in college. I deleted my Instagram. I don't even know if I have a Facebook or whatever is out there. I would pretty much Snapchat my friends, and that was it. And now I'm here. It's been very crazy the whole ride that it's been for me. And I'm not saying make a social media to do what I do, but make a social media to control your digital footprint, to control your image, so that down the road, you have leverage and control over who your digital person is. Refrain from posting inappropriate stuff. I promise you the picture will look just as good if you just put the beer down or the drink down. It doesn't make it look any cooler. Nobody cares that you have a beer either way, so just put it down. And you'll never worry about it. So that's what I always tell people. And just, if you're gonna, I don't know, seniors probably are 21. If you're gonna drink, just, don't go on your social media while you're drinking. Do it after, but not while you're drinking, because that's when you make mistakes. So that's my little two words on social media. Any other questions? Was this helpful? Like, I don't know. Like I said, I don't really know. I honestly, I'm glad I was able to help out and answer your message. I get a fair number of messages, and recently, I don't know if everyone's like looking for this type of experience all of a sudden, or someone told pre-med students that this should happen, but I've gotten like 50 plus requests to do this in the last week. So you just got there first. So I'm glad we're able to do this though.
Awesome. Thank you so much. It is, if you want to stay till 9, if anyone has any questions, they're allowed to unmute themselves now.
Yeah, please do if you have any questions or anything. Like I said, I think you'll have my email, obviously. I do look at every single message that comes in on Instagram. Just please don't start it with hi. That is the least helpful subject line, because I don't know if you know anyone that has a large Instagram, but there's like things go into a folder. They go into different folders, and so it goes into a request folder. So people that just send a message that says hi is useless, and I just think it's spam and don't read it. So anything other than hi is helpful if you're trying to get someone's attention. But also you have my email, it's seethemedlife@gmail.com, and I answer all those.
Perfect. Okay, so says any questions? I would like to thank you for being here. This was a really extremely helpful session, and thank you for all your advice.
Very welcome.
Thank you.
Yeah, of course. I hope everyone has a good night, and good luck.